Hi, my name is Daniel Kline, and I'm the lead author of the Injury Prevention and Rehabilitation of Throwing Athletes independent study course. And this is
Sure. My name is Chelsea Martin, and I am a co-author on this monograph, as well as a second monograph on windmill pitchers that we'll be covering in the next couple slides.
so one of the things we want to talk to you today is just kind of how do we treat these throwing athletes? Like, they're fun athletes to work with, and we want to help you get through this by kind of sharing a little bit of our monograph with you. So a throwing athlete walks into the clinic. What do we do next? What do we look for? What are the types of injuries that these athletes have? These are the common questions that we get asked by colleagues within our clinic and across the country. So what do biomechanics research look like and tell us? How are the throwing motions similar? How are they different? What are the common injuries in the throwing athlete? And do they vary? Are there contact injury differences and non-contact injury differences? And then how do I return this athlete to the field? That's the number one question that your patient's going to ask is, when can I return and how do I get there? And then that's the same question that therapists want to know is, how do we get these athletes back on the field fast and safe? So that's what our monograph is going to help us with today, is just explaining how we get those athletes there and moving forward. So topics covered on the monograph are the biomechanics of the baseball pitcher. Since that's one of the most commonly talked about athletes in the throwing world, we hit on the baseball pitcher in great detail. And then with javelin and football athletes being the other two most common throwing athletes in the United States, we also compare those mechanics of the baseball pitcher to them and how they are different. We also look at common faults that go on in the baseball biomechanics. That way we can help you correct those at each phase of the way of the pitcher's motion. When we're looking at elbow, we'll be looking at shoulder and elbow injuries specifically. So the upper extremity, while baseball is a full body sport and throwing is a full body activity, we want to focus in on the shoulder and elbow because they comprise the majority of the injuries these athletes are going to have. There's very much different physical and environmental considerations for these athletes, both from an internal and external loading standpoint. So we want to talk to these athletes about how do we return each athlete to the field. So we go through a phased approach of returning your athlete to the field, going through tissue extensibility, returning, going through strengthening, and how do we re-engage these muscles in appropriate fashion. We also talk to you about how do we go through a proper plyometric program, as well as what does the appropriate throwing program look like and how do we create one of those. We've also supplied an example of a extended throwing program within the monograph that will help a typical UCL type injury athlete return to the field. So it's a great example for someone to base a throwing program off of. One of the great things that we put in the monograph that all of our authors do is a centering technique. Now, this is that phase 2 portion of rehabilitation. This is after we've started to return our patients' range of motion back. We want to start going through how do we get them to center their joint. And so centering is literally just bringing our patient's glenohumeral joint into socket and getting it into the center position, because that's where our rotator cuff muscles work most effectively. So we supply a table that goes through the open and closed chain progression of centering so that your athlete can function in both ways. Some athletes do better with centering and closed chain. Some athletes do better with open chain. So we wanted to make sure we provided examples of how to get through those as well. And so kind of going through our open chain progression, we can kind of see here. So when it comes to centering, we have to cue our patients to do this. So centering begins with our picture on the left of just in our relaxed position. Picture 2 is our full scapular protraction. Now, just squeezing your shoulder blades back is going to over center your joint, and it's going to overtax and make you very rigid to moving your arm. So we try to teach the patient what their full strength is and then have them relax and then re-engage to 50%. That 50% pull is a happy medium. This is going to allow us to start engaging the rotator cuff. So for our patients, when we start their centering, we start them in this nice 50% position and just start jostling their arm and starting to get them used to firing their rotator cuff against someone moving their arm. But then as we progress, we'll start adding in things like external rotation, pressure, and isometrics. We'll start working our athletes through their full external range of motion while maintaining that glenohumeral centered position. Now, in this case, we didn't have a towel roll to help support us, but normally you'd like to have a towel roll underneath the elbow and your hand on the glenohumeral joint, just so that you can feel that they're maintaining that position the whole time. Once your patient has mastered something as surprisingly difficult as just being able to control their arm in a center position and fight resistance, then you can actually progress to the harder phase, which is being able to center your glenohumeral joint through ranges of motion of flexion. Now, again, we like to start with manual cueing to make sure that our patients learn how to do this. And we all do this in some form or fashion with scapular retraction and external rotation exercises. But this just allows us to be a little bit more specific and a little bit more focused on how do we really make sure this patient is ideally strengthening their rotator cuff. So all of our patients start their strengthening here with centering so that they know how to get their joint in the right spot so that they can be successful when trying to throw a ball overhead, and you don't want to have too much pain in the front of your shoulder from it sliding forward.
All right. And so now I'm going to be talking about the second monograph from this amazing co-author group, which is covering injury prevention and rehabilitation for fast pitch softball pitchers. And so this was a phenomenal opportunity for us to be able to just give some space for this particular pitcher, because for some of your listeners, it's oftentimes when we see a windmill pitch, it is so different from the overhead pitch, right? So thinking about, how we can kind of integrate some of these concepts, especially around biomechanics within our treatment program is really important. And so the common questions that came up, whether it was talking with other colleagues and when we were working with the author group about, what are some of the common questions that we think that clinicians would want to answer in order to be able to treat these athletes, is similar to the throwing monograph, is thinking about the biomechanics, but specifically to the windmill pitch. And how can we apply this to our treatment plan? Because even though it is a unique motion, there are some, specific concepts that can be easily integrated into the clinic. Again, thinking about that phased approach, if we're thinking backwards to, when we do clear our athlete to return to sport and then gradually work up to that, think backwards, think about how can I grade and phase my treatment approach to make sure that, we're giving them the best opportunity to meet the demands of their sport. And then the other concept around that is thinking about pitch counts and overall work volume, because oftentimes with these athletes, there isn't any limits to pitch counts and how many tournaments that they're playing. And so knowing that, it's likely that they came into your clinic because they had poorly managed workload. And so, what are the available guidelines that are out there? And this monograph at least gives you kind of that first look at what, rules of thumb and guidelines that you can use. Even if the research is not behind it, at least being able to educate your athletes to a better workload management that likely ended them up in the clinic in the first place. And then finally, thinking about specifically, when they get to that return to throwing and pitching phase, what type of pitching plans are out there? And so if we look to the literature, we also, if you were to do a Google search, a lot of times it's just based around baseball, which is great. We need that. But if we really want to cater to the windmill pitch, they're not really required to throw overhand to the degree that a pitcher or even a position player needs. And so this monograph provides some great resources for the clinician to have a more specific throwing program that is more catered to the windmill pitch, where they're not having to do excessive amounts of overhead throwing to get to the windmill portion of the throwing program. And then the second piece of that is, a lot of these athletes too, pitching might be their primary or their secondary position. So we provide some additional throwing plans to help the clinician kind of game plan around that. And so one of the things that I wanted to talk about that we cover in the monograph is just kind of a really high zoomed out view of biomechanics, because I think this is the mystical part of the motion, is that it looks so different from throwing. But I think it's really interesting to kind of bring it back down to phases. And so if you look at the wind up phase, stride foot contact, acceleration and release, deceleration and follow through, these are broken down very similarly to an overhead throw or a baseball pitch, which I think is a good place to start to try to demystify it a little bit. And so if we're thinking about, okay, that's great, but then how can we apply this to the clinic? There's two points that I want to highlight here. The first being the wind-up phase, or sometimes you'll hear your patients refer to this as the dry phase. And so this is when the athlete is still on the mound. They haven't quite launched out into the stride position. And so the picture below shows a type of exercise that we provide in the monograph where she's getting into that dry position, particularly in that second picture. The first picture is the start position. The second picture is kind of that drive position within the windup. And so trying to engage more of that hip hinge to get the posterior chain activated so that she can really propel herself off the mound. This is a great exercise to try to integrate even early on in the rehab phase. So for instance, Daniel went through a lot of the centering techniques that we do. And he talks about how that can be really challenging for athletes at any level to be able to do. And so sometimes they get fatigued very quickly. One way to incorporate some of this, kind of lumbopelvic control and drive position is to do this on their rest breaks. And so it's a really nice way to be able to allow them the rest break and recover in between sets, but then also, integrate some more sport specific motions. And so the second portion that I want to highlight is during that stride foot contact to acceleration and release phase. So during this phase, similar to baseball, it's a very high kinetic point during the pitching motion. So ground reaction forces are exceeding percentage of body weight. You have high distraction forces at the shoulder. And so what does this mean? It means that the athlete needs to have really solid lumbopelvic control. And so the second exercise that we provided here is you can get into like more of a stride foot phase during that first picture that you see on the right, and just kind of isolate that kind of shoulder hip separation that they need to fill. So you're applying some resistance from a band that's pulling them forward where they're having to control against the band, and then working through some of that hip shoulder separation while they're trying to control the position. And then as they are able to control that, you can then move to the second picture shown here where they're actually having to control against resistance and balance on that front side. So again, these are easy examples of how you can integrate this even in the early phases of rehab while they're trying to build up some of that overall endurance of the cuff muscles and understanding how to center before integrating both upper body and lower body within the later rehab phases. And so again, just high level, along with those biomechanical concepts and how to integrate that into the clinic from a phased rehab approach. The pathologies that we'll cover really are the shoulder, elbow, and trunk pathologies. Both in the throwing monograph as well as the softball monograph, we acknowledge that lower extremity injuries do occur. But for what we see in the clinic, we really wanted to give space to these trunk and upper body injuries that are specific to the throwing athletes in the first monograph, but then also to windmill pitchers as well. Figuring out those return to sport protocols, being able to implement those return to throwing or pitching protocols that are specific to the athlete. And then finally, just doing an overview of what is available for arm care programs, along with those pitch volume recommendations. There's a little bit out there that's available for windmill pitchers, but just kind of giving a high level as well as providing expert clinical opinion as well. So really excited to be able to share both of these monographs with you all and hope that you find a lot of value in them and it improves your clinical practice.